So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Everyone, welcome to this afternoon on the West Coast, Pacific time. Special edition, Lung Cancer in the Living Room. I'm Danielle Hicks, Chief Patient Officer here at Go2 for Lung Cancer. For those of you who might not be familiar with the living room, and I know a lot of you in the room are, but some of you watching from wherever you may be today might not be, and I hope there's a lot of you. This is a program that's been, probably 14 years running now, where we bring to you live and in real time conversations from key opinion leaders around varying aspects of the disease. We are thrilled to have you all here today. Just a quick reminder before we jump into the topic and some introductions of these lovely people sitting to my left, that this programming is for you. It's intended for you. So please ask questions throughout. There is no such thing as interrupting when we're having these conversations. And that goes for the folks that are watching online too. Please enter any questions you have in the chat. One of my lovely colleagues back east, Miranda Goff, who is on the Patient Support Services team, is moderating, as well as my lovely friend over here and other colleague, Jennifer Hughes. So we will make sure to get your questions to the panel as they come in. Tonight we're going to be talking about biomarker testing, and I think some of you know that biomarker testing and improving the rates of those being appropriately tested, not only at diagnosis but at progression, is a huge goal and what one of the goals here at Go2 for Lung Cancer. We want to ensure that everybody who qualifies is getting appropriate testing when they need it. And tonight we're putting a little spin on it, or today, sorry, I'm so used to doing this at night. Today we're putting a little spin on this by having a focus on one of the targets, and that's KRAS. You guys have heard us talk about varying biomarkers. KRAS is going to be the one we're focusing on today, and we're doing that because my friend here to my left, Terri Conneran, fellow non-profiteer, is that a word? I'm not sure, but and friend is not only a survivor, but she's the founder of the KRAS Kickers. I think you guys have also heard us talk in here about the different biomarker groups kind of banding together and supporting one another. So Terri is a volunteer extraordinaire for her own very important organization, and we love that Go2 and the Kickers are partnering in this way. We do partner in other ways, but we're really excited to be partnering in this way today. And then Dr. Blakely, who is local to UCSF. I could run through bios and talk about who they are, and it would be very boring and not very personal. So I'm going to allow each of them to introduce themselves and tell me why this work is important to you. Terri, we'll start with you.
Thanks for having me here. Okay. This is like such a treat. This is my first time to the living room, like here alive. I'm a 7-year lung cancer survivor, and what was the question? What makes me?
Why do you do
why
this
do
work?
I do this?
Why do you do this?
When I felt so disconnected from having lung cancer, even in lung cancer groups and amongst neighborhood, and not knowing how to answer the questions that are posed to us, about the smoking and this and that and everything. I just wanted to change it. And I'm one of those people, it's just, I'm either part of the problem or part of the solution. And so I just feel like maybe if I keep running now, I'll run cancer.
There it is. Dr. Blakely, how about you?
Well, thanks for having me, first of all. It's great to be back. I got interested in cancer research now 20 years ago when I was doing my graduate work back in Philadelphia. And my first interest was, it's just a very interesting disease, mechanistically, biologically. But then when I started to work with patients more, in particular cancer patients, now that's what really drives me, is to make treatments better for all of you who are, have these lung cancers that we're really trying to improve quality of life, length of life, and everything for.
I love that. And Dr. Blakely is MD, PhD, University of California, San Francisco, as I think I mentioned, UCSF, assistant clinical professor, Division of Hematology, Oncology in the Department of Medicine. So thank you so much for taking time away from doing what you do every day to be here for all of us. Some of the objectives today are really for everyone who watches, again, either live or post-live, to understand what we mean when we're talking about precision medicine and how precision medicine is meant to be individualized for the person and not what they are diagnosed with necessarily. And how knowing if you have a biomarker is really the first step in finding your best treatment. So we've got a lot to cover. We've got an hour to do it. So I think we're going to jump right in, and we're going to jump in with some basics, right? And so before we get into the whole biomarker testing and all of that, I thought we could talk a little bit about how far we've come. So the amount of progress that has been made. I've been working in this space for 17, 18 years now, and back then, those of you who are familiar to Living Room have heard me say before, like I'd go to these conferences and data would be presented and you'd want to be really excited, but the needle was moving forward in like months, weeks and months, right, with some of the discoveries and what we were trying. And since then, especially with sort of the advent of targeted therapies and immunotherapies, which I don't know if we're really going to get into that today, but things have changed drastically. So let's talk a little bit about the progress. How was lung cancer treated prior to this big burst?
Absolutely. It's really been quite remarkable, the change that we've seen. And I know it seems like a long time, but it's been a relatively short period of time. I started my training in 2009, so it's been 15 years since I've been seeing lung cancer patients. And at that time, we had chemotherapy and Tarceva, or erlotinib, and bevacizumab, or Avastin, was just starting to become available, and we were all excited because it had a 2-month survival benefit over chemotherapy by adding bevacizumab. And that's really every patient we more or less treated the same. We could identify the EGFR mutations, and those, typically we treated with erlotinib. And, I'm sure many of you were probably either on that or know somebody who was on that drug. It was a really challenging drug to take. The rashes were terrible, really hard to deal with. And it also didn't work that well, to be honest. Like, resistance occurred pretty quickly within about a year or so. And since we've had a better understanding of resistance mechanisms, we have new drugs like osimertinib or Tagrisso, and we've identified almost a dozen new targetable oncogenic driver mutations for which we have very effective drugs for. And then the immunotherapy revolution is just a whole other topic. But when I started this, I never thought that I would see patients with metastatic lung cancer who I thought were probably cured of their disease. And now there's no question that we're seeing that. So it's been tremendous.
It's pretty fantastic. I know a lot of folks in this room, a lot of folks who were diagnosed with stage 4 years and years and years ago and are living very outside of the diagnosis, normal lives with a great quality of life. So today's conversation being focused on biomarker testing, targeted therapies, I want to start a little bit like a 101 about what do we mean when we say biomarkers? What is a biomarker?
Sure. So there are really kind of 2 types of biomarkers that we think about. So there's what we call a prognostic biomarker and a predictive biomarker. And so by biomarker, we mean something in the biology of the tumor specimen, or it could be blood, or it could be something else, but it's usually tissue of some sort. We get a better understanding of the cancer at typically a molecular level. And ideally, it would be something that's a predictive biomarker. It means it's predicting that you're likely to respond to a certain treatment. And so that's why it's really critical for us to identify them so we know exactly what treatment patients should be on.
Who are we testing right now? I mean, there's different types, right? Non-small cell, small cell. Who are we testing?
I would say predominantly it's non-small cell. There are starting to be some interest in testing the small cell patients as well. There are new therapies being developed that we could talk about in more detail, but predominantly we're talking about non-small cell lung cancer. That includes adenocarcinoma, which is the most common that we see, squamous cell carcinoma, and then there's other kind of different subtypes like large cell or neuroendocrine type tumors. And to be honest, I think all of these patients and all of their tissues should be tested, because you actually don't know just by the demographics of the patient what they're likely to have. I've been surprised many times when I test a patient with squamous cell lung cancer who you would never expect to have an ALK fusion, they have an ALK fusion. And so everybody, in my opinion, should really be tested.
I think it's interesting because I remember back when EGFR was first sort of emerging and Tarceva had been approved, and I think the train of thought back then, and this is 2003, 2004, was, you know, the only people who were really testing are adenocarcinoma patients and primarily Asian female never smokers, right? And so when you look at that, and that's science and that's clinical trials, and we'll maybe get into the importance of clinical trials and discovery and continuing to push the needle forward in a little bit, but I think it's very, very, very relevant. So I guess my next question, especially when we look at what's gone on from a discovery standpoint in the last couple of years when we're talking about stages, because historically it was, I'm going to let you tell that story.
Exactly, Danielle. So historically, we've really only thought about using these targeted therapies for patients with stage 4 or metastatic lung cancer. And it's really been in the last 2 or 3 years that we've seen that these therapies are not only effective for metastatic disease, they actually improve survival and odds of cure for patients with earlier stage disease. And 2 examples in particular, EGFR mutated lung cancer and the use of osimertinib in the adjuvant setting for patients after they have surgery for an earlier stage disease. It's been shown now that if those patients are treated with osimertinib for 3 years after surgery, that they live longer than if they had never received the drug. And so, similar to the breast cancer field, I would say we're moving these drugs earlier and earlier. And in my mind, the earlier you can treat the cancer in terms of its kind of progression, the better. Because once you let the cancer progress and grow and develop new mutations, it gets harder and harder to treat. And so the earlier we can intervene with these drugs that we know are very effective, the better I think the outcomes are going to be.
Yeah, and I wanted to bring up the early stage because I think it is so new. And we're going to get into some of the challenges around biomarker testing a little bit later, but it's important for people who are diagnosed at the earlier stages to understand this so that they can have these conversations with their healthcare providers. And Dr. Blakely used the word adjuvant, and just so folks know, that is treatment like post-surgery. So you go in and you have surgery, and I think, again, historically, it was like you have surgery, the hope is for a cure, and we're going to send you on your way. But the reality of that is the recurrence rate was still too high for anyone's liking. So in understanding what this looks like post-surgically and how we can treat systemically instead of just, we're going to cut it out and be done with it, is making a huge difference, to Dr. Blakely's point, in survivability. So when we look at this testing, how is it done?
Sure. So typically, it will be done on the biopsy specimen that we obtain from diagnosis. So sometimes that's from a surgery specimen. Somebody has a mass on their lung and they just go right to surgery. That's removed and that's sent to the pathology lab. And basically, it's a DNA-based test typically. The DNA is extracted from the tumor sample. It's sent off to the lab. And these days, we're sequencing, roughly 500 or so genes that are thought to be mostly likely involved in cancer, and identifying specific mutations in those genes that might be relevant for a given patient.
And then, so we've got the tissue option. What about liquid biopsies?
Yeah, so liquid biopsies have also been a real, I think, revolutionary new tool, and that they're allowing us to, instead of maybe putting a patient through an invasive biopsy, to actually just take a blood sample, send that to the lab, and we look for what's called circulating tumor DNA. So it turns out that a lot of tumors will shed their DNA into the circulation as the tumor cells die, just as part of the normal life cycle of the cancer. And technology has been developed that can detect that DNA and determine exactly what mutation is driving that cancer. It's not 100% like a tissue biopsy. I would say about 90% of the time we're able to get enough tissue to do the sequencing. For liquid-based, some tumors don't shed their DNA, so it's closer to maybe 80% that we can detect something there. So sometimes we can't see it, in which case a follow-up biopsy would be needed. But when we can detect it, it's great to allow the patient to avoid that invasive procedure. And it's usually actually much faster, the turnaround time. We get it typically in about a week, whereas for tissue, it can sometimes take a month or more.
Yeah. In spite of that so tissue's still the gold standard is what we're saying, but liquid biopsy is a good option, or a good sort of in tandem in some cases option to do them both at the same time. How important is it, in your opinion, and I'm talking about original diagnosis, we've been talking about potential progression right now, but how important is it that a person diagnosed with non-small cell lung cancer have this testing done and the results back prior to starting their first line treatment?
I would argue it's one of the most important things, right up there with the decision about surgery versus no surgery. I think that's the first decision we have to make with patients, whether their cancer can be resected with surgery. And as we talked about, some of these adjuvant therapies come into play even in the surgically resectable. There's also neoadjuvant therapy. It's really important to know what might be driving your cancer. If there's a EGFR mutation, just as an example, we might not use neoadjuvant immunotherapy. And by neoadjuvant, I mean treatment prior to surgery. So I would say it's right up there with that decision of surgery versus no surgery. It's just knowing exactly what the molecular features of the cancer are.
Yeah, and I think it's hard, right? In talking with patients as often as I do, and Terri, I'm going to get to you in just a second, that waiting is hard, right? Somebody finds out they have cancer and they want to start treatment yesterday, or sometimes the day before yesterday, right? But it is important when we're thinking about, well, I'm going to let you finish.
Yeah, absolutely. Thank you for clarifying that. So that certainly you can start treatment right away, but the best way to do that is if you need the therapy, meaning you have a lot of symptoms from your cancer, and sometimes we don't want to wait. Sometimes we do want to jump into treatment. The best approach would be to do just kind of standard chemotherapy, not add on the extras like the immunotherapy to it, and then get the biomarker testing results back, and then you can kind of refine what you want to do. Do I switch to an EGFR inhibitor? Do I switch to an ALK inhibitor? Obviously we're talking about KRAS today. Mm-hmm. Is there any room for switching to a KRAS inhibitor, mm-hmm. that sort of thing? And the reason that's really important is the immunotherapy, it turns out, seems to make some of these drugs more toxic. So if you use immunotherapy and then go on one of these targeted therapies, you're more likely to have one of these what we call immune-related adverse events, which is basically your body's immune system being activated against your normal tissues like your lungs or your heart or other organ systems, which we absolutely don't want to happen because that can be life-threatening.
I want to step back for 1 second, and this isn't in the agenda, but it popped into my mind based on a recent conversation I was having. So potentially for an early stage patient who is not surgical for various reasons but are having radiosurgery, do we still need to do the biomarker testing prior to radiosurgery at the same time? Is there anything looking at that right now?
Yeah, I mean, I think so. The biomarkers we'd be looking for would be the molecular testing that I was talking about, so the DNA of the cancer, and then also PD-L1 or PD-1 testing. So that's a marker that helps us determine whether somebody's likely to benefit from the immunotherapies that we have available to us. And I'm sure many of you are familiar with what immunotherapy is. by immunotherapy, I mean these inhibitors that go in and block interactions between cancer cells and immune cells that are blocking the immune system from attacking the cancer. So we want to kind of unleash the immune system against the cancer. And we know that tumors that have high levels of a marker called PD-L1 are more likely to respond to those treatments. And so sometimes that's helpful to have even before the radiation. It wouldn't necessarily make me stop doing the radiation, but there's now data suggesting that using those treatments after radiation is complete can be life-prolonging therapy as well.
Yeah, it was just something I was curious about, because when we think about surgery as well as radiation therapy, it's localized treatment, right?
Yeah.
So adding some sort of systemic treatment to it.
Yeah.
Okay, that was helpful. Just a quick show of hands, and I'm going to jump to Terri. How many of you in the room, and it's not mandatory that you raise your hand or participate in this at all, received biomarker testing at diagnosis prior to your first-line therapy? Yeah. So that's pretty good. And I think some of that is indicative of where we live. But,
Yes.
but I think that's pretty good. So Terri, I want to jump to you really quick. Tell us a little bit about your own diagnosis and what that looked like.
Okay, well, when I was first diagnosed, they did do my biomarker testing, but I didn't know that's what it was. Okay, they sent it away apparently because I presented as though I was a stage 4 patient with fluid in my lungs, which was really a result of the biopsy that they did. And that's kind of what even prompted them to do it. I'm from Charlotte, North Carolina. I was being seen at that time by a community local oncologist that just kind of fed through the system. And so that's what they did do it. And when the results came back, which I didn't know what they were, the results back, the doctor just said, okay, we're going to go do chemo. You're going to keep doing chemo, and then we're going to cut your lung out. And that was it. This is the level of involvement I had in the whole process. It's like, okay, well, do what you got to do. Let's get it out of here. And I ended up being just a stage 3 patient instead of stage 4. So they didn't realize that's what the problem was. Surgery, whatever, and had no disease for about a year and a half. And then I started having recurrences. And at the recurrence and getting more involved in lung cancer groups, you know, like Go2 and being a phone buddy and all this sort of stuff. You hear about getting second opinions. You know, the biomarker isn't like this theoretical thing. It's not a genetic, like I inherit it type of a mutation. My doctor kept calling it genetic.
Yeah.
And cancer runs in my family. So that was more scary with my kids. So I wanted to know what it was. But I didn't go out for a second opinion until I had 2 more recurrences. And at the second opinion doctor, big cancer center, right? And they said, that's when they found out that I had this KRAS. You know, most of y'all know, right? People break up here by our groups, you know, because that drug works for EGFR, is not going to work for KRAS or ALK or what have you. And I just wanted to connect with other people. That's how KRAS Kickers started. But it was mostly because I didn't know what I was. And it was truthfully kind of disturbing to walk into the doctor's office and she says, well, they did your reporting. Here it is, first time and at recurrence, and we did it again in your KRAS G12D, which is meaningless to me. And so that's kind of like what happened. And then from there it's like, oh, so I've got something. What does this mean? And what does this look like? And then I really got into this.
Yeah.
But I lost all faith in my doctor when I found out it had been done. And as I had learned how to advocate for myself, like from doing, you know, listening and what have you, asking the question and asking, she just kept saying, you don't have anything that's driving your cancer. Well, that's true. I didn't have anything targetable, but I did have something. And that's what really was a burr under my saddle.
Yeah.
Can I just?
Yeah.
I mean, I think that's really important because, well, I'm sorry you had to go through that, first of all. But just because something we don't have a drug for now doesn't mean there aren't trials being developed or are trials available for it in the future. So when, your doctor looks at the report and it says nothing targetable, you should still look at the report and say, okay, well, is there anything there that there's a clinical trial for? Is there any new research going on into that mutation that they're saying is not targetable right now? Because who knows, maybe a year or two from now it will be. So I think that's really important.
Well, it also kind of tells us too, like who I can connect with.
Absolutely.
Okay? Because I want to see, to me, hope. I mean, we've got it on the back wall. To see hope, I want to see somebody who got through what I'm doing, and then I know what's going to be next, so I'm never caught off balance like that again. That's the whole thing.
Yeah.
And if they have the same thing as me, it's like just knowing that I'm not the only Martian or something is powerful.
Absolutely.
I think it's interesting, and that's a perfect segue into some challenges around biomarker testing. And one of the things I didn't have on there was this healthcare provider to patient conversation, shared decision-making conversations. And, I think this is a challenge and a barrier across the board. Docs only have so much time with their patients, right? But these are gaps that organizations like ours can help fill, to be like, well, this was my experience, and this is what this looked like, and get answers. Well, you get answers to questions you didn't even know you had, right? But it also it alleviates you taking up the 20 or 30 minutes you might have with your doc at his or her appointment to be talking about maybe some more important things. And I also want to say, the community hospital setting, particularly in more rural areas, and again, the veterans here to the living room hear me say this at every single living room. Things have changed so fast and furiously over the last couple of decades, particularly in lung cancer. And when you think about this general oncologist in the community setting, they're treating everything that walks in the door, whether it's a solid tumor or a blood cancer. And for them to be expected to know everything there is to know about whatever might walk through the door, in my opinion, is unfair. But there are resources. But this is why I think programs like this and the work that Terri's doing with the Kickers is so important, because patients who are empowered can then go back and have these conversations with their healthcare providers wherever they may be. I mean, I've had patients over the years say to me, why did I have to come to you to find this out? Why didn't my doctor have this conversation with me? And maybe it was time, maybe it was because he or she didn't know because it just happened last week. I don't know, right? But docs that work in that type of setting don't have the luxury of specializing in one or two different types of cancers. So it's sort of up to us, right, and our caregivers and our loved ones to kind of do that footwork for us. I think one of the other things, and I'd like Dr. Blakely's thoughts on this. Why do you think that biomarker testing is not being fully utilized at diagnosis? Do you think it's a knowledge?
I think that's definitely part of it. I mean, you brought up some great points. At an academic medical center, I only have to really know lung cancer, and I don't have to treat breast cancer patients or colon cancer or whatever. And as you said, the rural community oncologist has to see and know how to treat everybody that walks in the door. Maybe they're seeing 20 or 30 patients in a day, and they just know that, okay, this chemo plus immunotherapy works pretty well for most people, so everybody's just going to get that. And they just don't have the time to learn all the details about every cancer that they're treating. They know maybe one therapy that's a decent therapy, and they're going to offer that to everybody that walks in the door. So that's part of it.
Yeah.
Sometimes people, I think they just don't know. They don't know the latest. They don't know what's going on. They don't know, where to send the sample to, or, that maybe a liquid biopsy could be an easier way to go about things and get a quicker result than waiting the month for the tissue results to come back, that sort of thing.
And I think that's where, again, not to put more burden on someone diagnosed or their family members, but I've talked to thousands of patients over the last 20 years that came to us in great despair, right, and didn't leave this place without a ton of hope. And that was because they finally were understanding what they were going through, what their sort of marching orders were insofar as taking back control, I think, of something that feels so control-less, right? Like I have no control, but I can control this, and I can have these conversations.
But can I say, I think part of it is the anticipation as a patient from every movie I've ever seen. Person gets diagnosed with lung cancer, they go in and they get chemo.
Right.
And so if they can't cut it out, and so it's already been pre-programmed. And if my doctor says those two things to me, I'm like, oh, okay.
You just accept
I just accept
Yeah.
it. And so that's where the real divide is, that gap that we keep talking about. And there's so many across the channels, and it's so much more important even today to get see a specialist, right,
Yeah.
that has an idea.
I think that's a great point. That's why I keep thinking about it. I think maybe, and Danielle, you probably know this way more than I do, that not everybody realizes that there's different kind of levels of care out there. That you see, one oncologist is not the same as necessarily somebody who has really specialized training and knowledge in your specific disease. So I think that's an important message to get out.
Yeah, I think so too, and it's one of the things we encourage not only in this programming but throughout all of our touch points with people diagnosed and their loved ones, is this idea of second opinions, right? But to your point, Terri, people trust their doctors, right? They should, right? They want to, but to understand that doctors are human, and human error is a real thing for all of us, not just doctors, I think is an important thing to pay attention to. And I think explaining to people that you can go to UCSF and get a second opinion from somebody who specializes in lung cancer, come up with a treatment plan, and then go back to your community and have your treatment done in your own neighborhood. You don't have to travel back and forth to UCSF or Cedars or NYU or wherever, right? I think people don't understand that either.
Exactly, and the community oncologists, to be honest, are happy to do that. I've never really come across somebody who didn't want that extra, opinion.
Yeah.
Because it gives them some reassurance about that they're going to do the right thing for the patient.
Yeah,
so
I agree.
Absolutely.
I agree.
My hesitation to get the second opinion was all my own fault. And so I was my own problem. Do you know what I mean? Because I was confident that my doctor wouldn't be receptive. And so when I did ask her, she's like, oh yeah, here's where I would refer you to. It was such a relief, but I didn't know it was going to be that easy.
And it's so interesting, and I think that is a real sort of thing, not just with a cancer diagnosis,
No.
right? It's like I went to my doctor for XYZ.
Yeah.
I'm just going to do what he or she says. So how do you think, Terri, we can, as advocates working in this space, talking to people, how can we help people? And maybe it's just a story like yours, saying I was my own problem, right? Like maybe it's just saying, hey, I was my own sort of worst enemy, and finally getting to this place.
Well, I mean, I think part of it is what we're doing here, having these conversations, is having the dialogues. I don't play in policy and research funding and stuff. I'm sure that there's ways of fixing things there that are beyond my scope. But I think so much of it is the modeling of how to ask the question, hearing the answer, reading the conversations. And it's not just the KRAS Kickers, it's all these different groups. We're active like in Facebook groups, and in many ways we're more active over the weekend than we are during the week because everybody's got real jobs and real lives, okay? But when the real problems happen, it's Saturday night, 2 in the morning. So, that's part of it. But where are these gaps, where are these things? This is why I'm screaming about it, right? I mean, I've got, I'll show you my little stickers, but that's why we've got these little stickers, okay? Because the KRAS holes, okay, represents those gaps. And sometimes I'm part of the problem, okay? Sometimes I'm part of the solution too. And whether that's, I didn't know or didn't get the test or didn't get the results, those things are all gaps, those are problems, those are barriers. And I think that by talking about it, having an awareness around it, even if you didn't get like your full biomarker testing and you get a copy of your results, even if you didn't get it up front, at recurrence, you've become educated enough to become empowered. And that empowerment means I've got enough energy, guts in the tank, to just ask the question, right? And I think that's a lot of it. We don't know what we don't know. Then we start asking, then we start learning, but then we don't want to sound stupid. but we want to know. And right, I mean, that's really what it is.
Yeah, it's that rock and hard place sort of place.
Yeah, totally.
Yeah.
And am I part of the problem? Sure, I'm always part of the problem. I know that. My computer would work all the time.
I think I do want to jump into KRAS in particular and kind of break down that, because I think there's a lot of excitement happening and has happened over the last few years in that area. But before we do that, one of the things we didn't talk about was progression. We've talked about diagnosis and the importance of it then. Why should we be looking at rebiopsying and retesting when somebody progresses?
Yeah, sometimes it depends on what the original oncogenic driver was in a way. But most of the time, a rebiopsy, or at least a liquid biopsy, can help us understand why it was that the cancer became resistant to the initial treatment. And that can lead to either identifying a clinical trial for a given patient, because you identified a certain mechanism and we know that they have this trial over at this institution, or we have it, our institution. Or you can identify another therapy that you could potentially either switch the patient to or add to the existing therapy that might be effective. And then I would say the third thing is that sometimes these cancers will just change dramatically at progression. The so-called small cell transformation is a classic example of this. And if you're just going along treating it thinking that it's a non-small cell the whole time, and you're continuing to treat with those types of therapies, and it actually changed to small cell, you're not going to be effective in doing that. So not everybody necessarily needs to have a biopsy to rule out small cell transformation, but everybody should at least have a liquid biopsy that's looking for mutations that make us concerned about that potentially would identify trials for patients or would identify other therapies that we could add on to their existing treatment.
Yeah, I think it's a great point.
Even if it's surgically removed?
Yeah, even if it's surgically removed. You mean like at recurrence, if you've been off of therapy after the surgery? I would say that the tissue biopsy is probably a little bit less important in that scenario, but I do think getting the liquid biopsy at a minimum to understand, potentially why is it that the cancer came back? Was there a new mutation that developed that allowed the cancer to grow at that point? I do think it's still important.
We're talking about resistance. There are therapies approved for that. There are multiple biomarkers. A lot of these biomarkers have multiple approved therapies for them. How is that decision made?
About which therapy to use? Well, usually, ideally, it's with the patient and talking to them about, I think I'll use ALK as a classic example, because there are like 5 different FDA-approved first-line therapies for ALK-positive disease. And they all kind of have their pluses and minuses about them. And coming to which one we should choose in the first-line setting is a matter of, well, how long does it typically work for, and what are the side effects? Or I would say the 2 most important things, and how is this going to affect your quality of life? And that's a discussion typically with the patient, like what are the things that are important to you? Are you willing to have more side effects, but potentially have a bigger upside of a longer time on the drug with the cancer under control? Versus are you really somebody who values quality of life as the most important thing, in which case maybe a different drug would be best suitable for that patient.
Does anybody have any questions? Oh, Ron Fong has a question. Ron Fong, oh my gosh, see what happens when I have my back to you? I'm so sorry.
So biomarker testing is important. Are there barriers because of insurance, or because of it's not in the guidelines for the community oncologists?
That used to be a problem. I don't know. I mean, are you still having patients run into that issue? Now that it's supposed to be covered by all insurance at this point, is my understanding. So for initial diagnosis, it should not be a problem at all. Sometimes we'll get pushback at the progressive biopsies and retesting, but initial diagnosis, it shouldn't be an issue.
So on initial diagnosis, do you recommend a broad panel? because I had a community oncologist assume about a patient and said, oh, well, you're Asian, so you must have this mutation. And that's all they tested for.
Oh, wow. Yeah.
And then they missed the fact that he was ROS1.
Right. I think a broad panel is critical, and so a broad panel being, it should cover every known oncogenic driver that we have a targeted therapy for. So, you know, we can go through the list, ALK, ROS, et cetera. In addition, it should cover other things that, you know, maybe there are therapies for on the horizon, I think. And one other important point, because a lot of these alterations can only be detected or are better detected by RNA-based sequencing. You know, the way that the cell, all of our cells make protein, the DNA is the blueprint. It, you know, makes a copy of itself into something called RNA that then makes the protein. And sometimes you can only really detect these alterations by testing the RNA. And so if you get a completely negative DNA-based test back, and your oncologist says, oh, you should just go on chemo, maybe ask them to take a second look and send it for RNA-based testing to make sure they didn't miss anything, because we've certainly seen that not too uncommonly these days.
I just want to touch, Ron, on so the single gene testing still happens,
Yes.
right? And I think that's part of your comment, right? Because that's a problem, right? Not only is it delays in therapy, but maybe not receiving the appropriate therapy because we're only testing for one thing at a time. So I know Go2 and Terri and Dr. Blakely and many, many, many others really advocate for that comprehensive look, not only for what we know we have drugs for, but what might be coming down the pike. And I think that's a perfect sort of segue into KRAS. When we think about biomarker testings and sort of if you have a whole pie and you kind of slice it up into what we know, right, is there, KRAS is the biggest chunk of that pie, and for many, 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 many years was thought to be undruggable. Like, you have KRAS, like, that's it, we don't need to look any further. Yeah. Let's talk a little bit about the explosion that has happened in this space and sort of what is coming along.
On the horizon, sure. So KRAS was the first oncogene identified in lung cancer back in like the early 80s. And there was no drug for it, as you said. And people tried different approaches about how to potentially drug it, and nothing was effective until these new KRAS G12C inhibitors came about. And we can argue about the efficacy of those. I think they leave a lot to be desired currently. But the point is, we're certainly making progress. And KRAS is not just one disease. There are, you mentioned, I think, G12D. There are many different forms of activating KRAS mutations, only one of which we have a drug for right now, the G12C form. So, you know, there's G12D, G12E, the G13s, and then a handful of others as well that are all potentially targetable and druggable. And we just need, you know, the drug development to occur. So it does make up the biggest piece of the pie, but like lung cancer in general, you have to look finer and finer to get exactly what the right therapy is for a given patient.
Yeah, I say that all the time. Again, those of you who are tired of hearing me talk, lung cancer, historically, and back when we started this conversation about everybody was sort of treated the same. So in the US, you had 225,000 people, 225, thank you, 1,000 people diagnosed every year. Everybody got chemo and radiation. Like, that was sort of it. But now it's really this series of, I don't want to call them orphan diseases, but rare cancers, right? Because the buckets are getting smaller, but the treatments are getting more precise. So when did you sort of jump in on this sort of, what made you decide to jump in on this train? How do you have these conversations with folks that, I guess, have been diagnosed with KRAS positive regardless of the subtype?
Regardless of the subtype. I think the most important part is, first of all, finding out that you have something becomes a part of our identity. And that's a lot of it. And I also feel that it's so important for patients, regardless of the type, to get information from more than one source. You know, these are great, but don't only listen to living rooms. You know, one single thing is not good enough. And so not being able to know or understand what a KRAS was, what it is, what it meant, or what I should care about, made me want to be able to take and translate that, simplify it, break it down so that it was less research-oriented, with less PhD, but also not for a preschooler. And there's this huge place where we don't know. And I needed to start out like I was preschool, okay, to understand it. But then I wanted to move on and understand better. And that's the only way I feel that I can become empowered as a patient. And so how do these conversations happen? Well, within the Kickers, which is what I'm most active with the KRAS Kickers, is we talk about what's next, what's happening. How come this G12D won't work? You know, I have G12D. How come my G12C won't work for me? They're like, it's one letter different. Well, now I understand. I've been to Kafan Showcase Lab, okay? Like, I understand what the pocket looks like. I understand what the difference is, that it's not just an alphabetic thing. It actually means it has a different biological composition. Oh, okay. Well, that makes more sense, okay? It's not I'm just being left out. So taking and having those things. And, you know, the Kickers is we don't just do lung, we do all cancers. And just so you know, KRAS is the most common gene, oncogene in lung, colorectal, and pancreatic cancers, okay? So it's the top 3 deadliest cancers. So there's a lot of us out there. And when I found out I was KRAS G12D, I was like, which is very common in pancreatic cancer, I felt like I dodged a bullet. I felt like I was lucky I got lung cancer, not pancreatic cancer. And so that was one reason why we became inclusive. But does it matter when I go into a conversation with somebody and I'm having a conversation and they're like, I've never met a Q61H before. And it's like they're long-lost siblings. Okay, now it doesn't, it's not going to change any treatment, okay? You know, I don't think they're going to run off and get married or anything. But, you know, but at the same time, it's like, oh, I'm not alone. I got this too. And really, we can change so little about what we have. The least we can do is surround ourselves with other people that have that knowledge and that hope to help give us that empowerment, okay, about what's going on, so we can know and learn how to advocate for ourselves, because it's all, at the end of the day, it's about our survivorship and what our lives look like, because we had that big awakening, that alarm bell that went off in our head. Boom, you've got cancer. Now what? Well, now I'm listening to the clock ticking. I want to be intentional.
Yeah, I love that. I know there are several folks in the room and some online, because I am being mindful of everyone's time. But I do want to touch on clinical trials, because folks who participate don't get thanked enough. They don't often know the outcomes of the trials that they were in or what happened next. But if it weren't for those people participating in those trials, a lot of us in this room and watching online wouldn't have the therapies that we're on right now. What's going on in KRAS? Anything? Can I expect anything at ASCO? I guess is what I'm asking.
Yes.
For sure. I mean, so we talked about the G12C inhibitors, and they made a big splash a couple of years ago. The first KRAS inhibitors that are FDA approved and show some efficacy in treating lung cancer in particular. Now there are drugs being developed that are entering clinical trials that can target not just G12C, but the other G12 variants, which is really exciting. And they also may even be more effective against G12C because they act in a slightly different way. They target the KRAS in the on position instead of the off position. So right now the drugs are only effective against the form of KRAS that's actually not even active. They kind of prevent it from becoming active. But if we had a drug that can target it even when it's turned on all the time, that would be even better. And so we see evidence of that in the preclinical data, and at least in, we're starting to see evidence of that in clinical trials as well. So that's, I think, the next phase for KRAS in the targeted therapy space. And then the immunotherapy, I think there continues to be evolution of new therapies that are developing there as well.
That's great. Did you want to say something? I felt like I interrupted you.
Oh, I just keep talking.
Oh, okay. That's okay.
Okay,
That's
no.
okay. Jen, I want to make sure. Yeah, okay. Somebody has a question.
What companies do biomarker testing?
Yeah, so I mean, there's dozens of them that are doing biomarker testing, and the ones that we've been talking about, the I would say the cancer genetic or genomic type testing, the primary ones are Foundation and KRAS and Tempus for Guardant, Guardant for the liquid-based testing. Foundation also has a liquid-based testing, but those I would say are the top three in my mind, the most comprehensive and most reputable that I would go to.
Mm-hmm. Yeah, and I think it's important to know too that a lot of academic centers have their own in-house testing capabilities, which also helps cut back on a little bit on time. Did you have a follow-up? Yeah.
How exact is biomarker testing? This person had different results from liquid to tissue. Wants to know how she could have one EGFR subtype with liquid and another with tissue. Does that make sense? I hope so.
So it's always hard to know without exactly looking at all the details of a given case. I would say that tissue is still the gold standard, however, and I've seen these discrepancies from time to time, and I trust the tissue results typically more than the liquid results. It could be, or it could be just, the limitations of the liquid testing.
So Ron asked about heterogeneity. Would you mind explaining that?
Sure. So the idea that cancer is heterogeneous, meaning that it's not just every cancer cell in a given patient is not the same. So they all started typically, we think, from a common progenitor cell. So it means there was one cancer cell that gave rise to all of the other cancer cells in that body or in that person. But they start to develop different mutations along the way so that you could have, literally dozens or if not hundreds of different kind of subtypes of that cancer in a given patient. And so you may, on a biopsy, detect one mutation that on a liquid test you see a mutation that was present only in another part of the cancer and somewhere else in the body.
So does that lend itself to also challenges around if you don't pull from the right spot in a tumor, could you miss something that's there?
Yeah, I would say when we're talking about driver oncogene mutations, they're going to be in every cancer cell in that given patient. It's these kind of what we call subclonal mutations. So when we start thinking about mutations beyond the driver oncogene, that's where it kind of more depends on maybe where you're looking. That comes into play more when we're looking at resistance. So if a patient has, and I think this is an important point, so if a patient has, say multiple sites of disease in the lung and the liver and say maybe the adrenal gland, and they're doing well, and then on a scan their liver tumor starts to grow. Well, you don't want to biopsy the lung lesion there. You want to biopsy what's actually growing because the lung lesion probably doesn't have the resistance mutation that is making the liver lesion grow. Yeah. So that's an important point.
Yeah.
But I think that resistance and being retested progression is what's so critical to knowing what your next step could be. We do know people that have mutated from, say, an ALK into a KRAS, or there's some other thing that's going on, or even two different primaries.
Absolutely.
There's so many more nuances to it, but I think it underscores what you started with. Precision medicine, personalized medicine means you need to take the whole person into consideration and look at that. and see what individual recipe it is that they have. And that includes, like, as a patient, knowing that you have the right and you should be encouraged to get a copy of your report, to make those decisions. And if you don't understand what it is, that's okay, but ask the questions and get informed.
I think that's a perfect take-home point. It's complicated, folks. There's a lot to know about a lot of different things, and we only touched on a couple. But I mean, we could talk for another 6 hours about any one thing that we talked about today, and we didn't touch on oligometastatic or oligoprogressive disease and what that might look like and how to keep an eye on that. And this again is why, again, in my very humble opinion, and in Go2's opinion, second opinions with folks who get to specialize in one area is such an important part of this journey. I hate saying journey. Experience. Something, I don't know, help me.
This chapter of my life.
Yeah, right. Okay, we are out of time. Does anybody else have any questions before I ask for some take home or what takeaway? Okay, no. Dr. Blakey, what do you most hope people watching will take away from this conversation?
I think there are many things, but biomarker testing is incredibly important. You should, if you're not getting it, and if you're not getting the report like you had, you should be asking your doctor for it. And one of the other problems, we didn't really touch on this, as you said, Danielle, we can touch so many topics.
Yeah.
These reports are not written for patients. Sometimes they're not even written for the doctors. Mm-hmm. I'm not sure who they're written for, but if you don't understand it, which most of the time you may not, ask your doctor to explain it to you. I think that's really important as well.
I agree, or reach out to Go2 and we can connect you with Lung Match. We have some really, really, really smart folks on our science and research team who help folks not only navigate their biomarker tests, their pathology reports, and help them to come up with those questions to come back and have with their conversations, but also will help them navigate clinical trials, because clinicaltrials.gov is a mess, just like our path reports from.
Yeah, clinicaltrials.gov, you have to know what you're looking for.
Yeah.
You can't just go and search for, I want to find out about lung cancer trials.
Absolutely.
It's not great that way.
Terri, what about you? What do you hope people take away from this?
Just being here was really pretty cool, because this is really kind of like a very empowering thing. I think that we should not drink water from just one well as a patient. And I want people to realize how important it is. Like, see, here we are, like, talking together, okay? They'll see us at the other events, and the unnamed events. But it's about getting that information, okay? Don't put all your eggs in one basket. I mean, I can come up with metaphor after metaphor. You guys know what you're supposed to be doing, okay? But it's your life. You are the 100% patient population in your body. You need to take it. You need to be empowered with it. And if you don't know what you need, ask one of these places, ask me, ask somebody else who's doing it, because that's the only way we're really going to get ahead.
Absolutely. Well, a huge thank you to Dr. Blakely and Terri for coming out and having this conversation today. As always, I just love these meetings. I hope everyone learns a little something new every time that they come, or a lot of something new would be even better. Our next living room, our regularly scheduled living room, is May 21st, and we have Dr. Jorge Nieva coming up from University of Southern California to really focus on clinical trials. Is a clinical trial right for you? How to navigate them? When we should be thinking about clinical trials as a best next sort of step or treatment option. We're going to dig deep. I will not be here. Those of you who heard me talk, this is our fourth living room this month, so I've probably said it 4 times. I don't know. But I will be celebrating one of my very best friends' birthdays. And in those 14 years we've been doing this living room, I think this is the 3rd or 4th living room that I will not be at. And it absolutely devastates me. But Go2's very own Courtney Granville, who's our chief research officer, is flying all the way out from the East Coast to moderate with Dr. Nieva. So big thank you to her. Our next Gathering Hope Community Social is on May 14th, 5:30 Pacific. For those of you who don't know what that is, it really is what it sounds like. It's a virtual community social gathering where people diagnosed and their loved ones can learn from one another. So we've got some veterans I see in this room who are consistently on there welcoming new folks to the group, helping bring this big old word into the lives of anyone who's been impacted by this disease. So please consider joining that. A huge thank you again to our panelists, to all of you watching live or coming back post-live, Onyx and Ash, who will take this 1 hour and change meeting and break it down into a more digestible, he'll pretty it up for us. Penn Media, who comes and sets this up for us every month, sometimes multiple times a month, for all the work that they do. Michelle Zay, who is not here today, but a big shout out because I have a feeling she's probably watching from her phone, even though she's on vacation. And the entire Go2 team for everything that they do for this community. I would be remiss in not acknowledging our supporters who, without their support, we would not be able to bring this programming and others to you. Amgen, AstraZeneca, Bristol Myers Squibb, Catalyst, Daiichi, Jazz, Eisai, Foundation Medicine, to take a deep breath, Janssen Oncology, Lilly Loxo, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, and Takeda. Long list of supporters, people who believe in the work that we are doing here and bringing to you. So thank you to them. I want to give a big shout out and a thank you to Ron over here and Wayne over there for bringing the lovely desserts. Sally, you brought dessert too?
No, Ron and I.
Oh, okay. It's together. So Ron and Sally and Jane for these lovely flowers that smell so incredibly amazing that she picked from her garden. Until next time, everyone, thank you so much for joining us and enjoy the rest of your day.
So I'll be brave if you're brave. I'll be brave, but only if you're